All right, I think we're ready to get started. Good afternoon, everyone. Thank you so much for joining us today. My name is Helen Hockey. I'm the Executive Director for the Pennsylvania Coalition for Oral Health, which is our state's statewide advocacy coalition. And we're here today to present an interactive discussion on a recently released report from PCOH that we think is pretty relevant to many different states and a lot of the workforce issues that they are facing. So just some housekeeping as we get started. We're going to be recording the webinar, and we do welcome questions at any time during the presentation. So you can type your question into the Q&A box that you'll see on your menu bar there on Zoom. And you can use chat as well. We'd prefer that you use chat for tech issues only, but we'll monitor that. So we'll keep an eye there. And I'm going to put, if you haven't seen the report yet and you're joining us just for new information, I'm going to stick the report link into the chat as well, so that you can follow along as we go through some of the different pieces of the report. So some of the snips that we're going to be showing you on the slides will be much clearer when you look at the report itself and download and review it from there. So just kind of wanted to give you that as an FYI. So with that, we'll go ahead and get started here. Now, our coalition, if you're not familiar, works directly with the Pennsylvania Department of Health Oral Health Program as a contractor. And Pennsylvania was one of quite a few states that were awarded a 4-year HRSA workforce grant back in 2018. And it was really focused on a number of different ways that we could improve the oral health workforce. So one of the projects taken on for that 4-year project was to analyze our current workforce numbers and to start to share the information out with interested parties and who might be interested in looking at those. So that's what we're going to be talking about today, is the information we've gone through as a result of this funding and this report. And I did just want to share some good news for those joining us from Pennsylvania. We were just approved as one of the 32 states that are, received the next round of HRSA funding. So we've got dollars dedicated to dental workforce from 2022 through 2026 now. So that's really great news. So now, next, just a little bit of background on the project. So I mentioned that, we were tasked with looking at these numbers and reporting them out. And Pennsylvania, I know we have a number of folks on from other states, but I think we're pretty unique in that we collect and publicly share a lot of data from our State Board of Dentistry. So if you are familiar, you know that we have a lot of providers certified and licensed through our State Board of Dentistry. And Pennsylvania does some pretty neat surveys every 2 years. And if you're a provider, you know what that's about, where you really can't get out of them and you have to provide some info. So what's really great is it gives us some cumulative data, both qualitative and quantitative, to look at and assess our workforce. So we've known, we've been tracking this information for quite a few years, and we know that right now Pennsylvania is facing a lot of trouble finding dental providers, and then dental providers are having trouble finding staff. And so we wanted to, put something together and share this as a baseline document for everyone to reflect on and review. So what we're going to do today is going to be more of an informal process. So we're not just going to sit here one at a time and talk at you. We're really going to have more of a discussion, more of an informative approach to this kind of commentary style, where we're going to talk about the report, talk about the pieces of the report, and kind of give you guys a guide of how to look at it and how to read it. So with that, you're going to hear from a lot of us. All of the authors of the report have joined us. So I do want to welcome, we've got Kelly Braun here today, who's the Rural Primary Care and Integration Coordinator with the Pennsylvania Office of Rural Health. We have Lauren Wagner, who was our student analyst from Mercyhurst University. Dr. Megan Baston, Assistant Professor for the Department of Pediatric at West Virginia University School of Dental Medicine, and Dr. Sean Boynes, President of Dental Medicine Consulting. So we're all going to be here today. You can ask us questions as we go through the different slides, and we're really excited about that. And we're going to give some, as I said, some commentary. With that, I'm going to go ahead and move on to the next slide here. Welcome, everybody. So as we take a quick look at the general synopsis of what this report did and said, you can see our key takeaways here. And I'm not going to read them all word for word because you guys can all see this, but overall, the biggest thing that we noticed was a pretty big decrease in the total number of providers out there for folks. We wanted to do a little bit of a deeper dive looking at the county level. And some of that stems from curiosity. Some of that stems from how do we develop solutions, and where do we target our resources to make sure that we're kind of affecting the communities that need it the most. And so that was something we're going to dive a little deeper into some of these different numbers. But we definitely did see some discrepancies between the different positions. So when we compare dentists to hygienists to dental assistants, we saw some different numbers there. We're going to talk a little bit about that. And then, we were able to do a little bit of a deeper dive into salaries as well, because, in order to retain dental workforce, you have to pay dental workforce. So it's very important for us to look at those numbers and see how we're comparing nationally across the country. So I'm going to go ahead and turn it over, I believe, to Sean for this.
Thanks, Helen, and hello, everyone. Thanks for tuning in for the reveal of the workforce report. The slide that you're sitting in front of you is sort of the go-to slide of just where the numbers are at. Overall, as Helen said, there's been a 10% decrease in the dental healthcare workers in Pennsylvania. We see the most severe decreases over the 7 years that we looked at. So we went back to 2015, looked at 7-year trends, was with dental assistants. They've not effectively rebounded from decreases in 2020. Overall, we saw about a 5.5% decrease in dentists over that 7-year period. With hygienists, it's interesting because we did see less of a decrease with hygienists that are located in rural areas compared to urban areas, which is the opposite of what we saw with dentist attrition. So about a 3.2% decrease in hygienists in urban counties versus 1.4% decreases in those rural counties. One of the promising areas is looking at the increase in certifications, which is what you see on the right-hand side of this graph. The public health dental hygienist practitioners, the PHDHPs, and the expanded function dental assistants, or EFTAs. As you can see, both have increased over the period of time that we've had data to review that. As I talked about in the opening with the dental assistants, we saw about a 15% decrease in dental assistants since 2015. There was a steady decrease when you go back in the traditional data, but nothing as abrupt as what we've seen in 19 and 21. From a national standpoint, we are seeing decreases nationally in dental assistants, and dental hygienists are not recovering at the rate that we would hope and expect. So with that, I'll turn it over to Kelly to give us a little bit more insight on a couple of the other pieces. Kelly?
Sure, thanks, Sean. So a previous report that our office had released, we actually completed some work for the Center for Rural Pennsylvania. And one of our recommendations through that report was this idea of a ratio between dentists and dental hygienists. And if we could have a 1-to-2 ratio. So for every dentist, there would be 2 dental hygienists working with that dentist. And when you look at these numbers, you can see we actually have pretty even numbers currently when we look at the 2021 data. Roughly pretty even numbers to be a 1-to-1 ratio rather than that 1-to-2 ratio. The idea being we could actually have more preventive services offered in offices and have patients on a preventive recall basis if we had some additional hygienists to go around. So unfortunately, we're not quite meeting that 1-to-2 ratio. We're just about at a 1-to-1 ratio. However, like Sean mentioned, rural areas haven't seen quite the decrease in hygienists as urban areas have. And so their ratio is actually a little bit higher, a little over that 1-to-1, but not quite at that 1-to-2 ratio where we would like to be. Next slide.
Thanks, Kelly. Kelly, if you don't mind saying a little bit about, I don't think we covered this elsewhere, but about the dental assistant to dentist ratio. Do we have that covered anywhere else? I just was curious if that was something worth mentioning here as well.
Sure, we can absolutely touch on that a little bit. So again, having additional assistants and even EFTAs, if we could have an assistant and an EFTA per every dentist, right? That increases the dentist's capacity if they're able to have those extra hands. And unfortunately, again, if we could have even a 1-to-2 ratio, that would be great. But we're not quite at that capacity. We could definitely use more assistants and EFTAs within the state to try to increase the capacity of dental offices.
Okay, thank you. Yeah, I know there was a report in HRSA, especially for federally qualified health centers. I think typically once a 2-to-1 ratio for dental assistants to dentists. So definitely can use some help there. Just a high level overview on this slide. And again, you'll definitely need to check it out in the report. It's a lot of little numbers. This is basically the best we could come up with when we start to look at how many dentists and how many dental hygienists are in the state. And so there's a lot of different sources for this information, which seems interesting. Like we shouldn't have so many sources for this information. It should be pretty cut and dry of how many dentists are there and how many dental hygienists are there. So, you know, the one thing I just want to draw the attention to from our perspective at PCOH is the top line there where we have our recorded numbers for licensed dentists and hygienists. Those numbers actually came from reports that we pulled from the State Board of Dentistry that said, you know, you can look at mailing lists and things like that, that if you want to, you know, purchase a mailing list to send out information on a continuing education course, you get that information right from the State Board of Dentistry. And so that's where those numbers have come from, which means that we have names and addresses tied to all of them. Which again makes it very hard to explain away those discrepancies. So just kind of wanted to give a little bit of a high level view that we pull those numbers from there. But at the same time, you know, when we reflect back on asking all these different groups for numbers, we see some pretty different things. So, you know, and I know Sean wants to say a little bit more about that.
Yeah, I think it's very confounding when you start to look at just how different the numbers are. There are some legitimate explanations. When you pull numbers, there's a lot of snapshot flow to this, that in a given month, you can have an increase or decrease in providers. But the amounts that we're seeing here are a little bit larger than what you would expect from a normal standard attrition from either cost of living changes or people moving in and out of the state, those inflows and outflows. I do think it's interesting on how the keywords are reported, and it does, depending on what the keyword is, come up with some differences. But when you start to delve in the numbers, the explanation of how to define that keyword really aren't as present as you would think they are. And so it does lead us to have sort of a different structure. There does seem to be two schools of thought generally, which is who are active in the field providing clinical care, and then who are all of the dentists. And when you look at the reports, they tend to shade that way, where one report that's really focused on access to care and who can get clinical delivery versus how many dentists does it take to make it all go around. And, you know, there are other dentists that are important besides those who are just providing clinical activity. Same thing with the dental hygienists. I will say about the dental assistants, there is a little bit more agreement. The United States Bureau of Labor Statistics tends to be used more often. And then ratios that are built off of sort of the departments of health throughout the countries tend to be used as well. So here it is. I think this is probably the most comprehensive evaluation of the number of providers in Pennsylvania to date. And the truth is there were a few others that we could have included, but there was some redundancy in those reports. But if you look at the reference section, we've included them all there. And I'll turn it to Megan, who has a couple of pieces on this as well.
I just wanted to report about how surprising it was to me to see all these different sources and the variation, because as a provider, whenever I would renew my license, I figured it was cut and dry. I mean, I got the demographic data all filled out the way the report wanted, and I figured I was counted somewhere as, number one, there it goes. There's a dentist right there, but clearly it's not that easy. And that was very surprising to me to realize.
Yeah. And some of it also comes from for folks like the dental assistants, which in Pennsylvania, we don't track with the State Board of Dentistry. So again, it's a harder database to maybe find. But I think too, something else that we have to realize is the different sources here where they're capturing it. Everyone, especially when we're using the State Board of Dentistry as a data source, every provider has the flexibility to list any address that they would like to list on their dental license. And so, it could be where they work, it could be where they live, it could be anything. And so again, we see some discrepancies too when we start to try to pull out Pennsylvania specific, because we would assume that a provider who has an address in Arizona is probably not providing dental services in Pennsylvania. But we can't say for sure. So I think there is some flexibility, and I know Sean mentioned the idea of, timing months. For those of you who have a dental license in Pennsylvania, you know that in the odd years we renew in March. And so if you check the numbers March 1st of an odd year versus April 1st of an odd year, you're going to get two very different numbers. So there can definitely be some discrepancies there as well. So we're going to move on to our next slide here. And I'm really happy and excited to have Lauren say a little bit about where all this fun color mapping came from.
So now we're going to dive into our county level assessments. So as one of the student analysts of this research project, one of my main roles were developing and creating these maps like pictured here on the screen. So here on the left, we have licensed dentists from 2015 to 2021, whereas on the right, we have licensed dental hygienists from 2015 to 2021. And both these maps are depicting our percent change in the state of Pennsylvania, but at the county level. So before even creating all these maps, I was provided with data from multiple entities where I was able to transfer it into Microsoft Excel, and therefore was able to calculate the number of dentists and hygienists per county in the state. So after I cleaned, sorted, and organized all this data, I developed a master spreadsheet where I was able to create a snapshot of the number of dentists versus hygienists. From our various research years, we were utilizing data from 2015, 2017, 2019, and 2021. So after all that was said and done, I was able to begin mapping out our things. So all the mapping was actually completed utilizing a visual analytics platform known as Tableau. So for each of our counties, I found the percent decrease from 2015 to 2021. And the platform ultimately assigned a range based on the data and the numbers that we had to provide a lighter to darker shade of that particular group. So here we can see on the key, the blue is the percent decrease, the gray is the percent increase, and the gold color is no percent in change. So as we can see, the lighter blue, as it gets darker, that indicates a more significant percent decrease. And this is why the percent increase goes from a lighter to darker shade. And just looking at these maps very briefly, I think what was surprising to me the most is the amount of blue that we have pictured here on the licensed dentist map to the left, just indicating that a lot of these counties had a percent decrease in dentists.
Yeah. And I think it's interesting. It's definitely more severe. If you look at these two side by side, I think you can definitely see that we've seen that decrease more severely impacting dentists. And one of the things that becomes an issue with that is, in order for dental hygienists to work clinically in practices, they have to have a dentist to work for. So even if the numbers are there, but there's no employer for them, we're still going to see that impact the populations. And so that's kind of, when I look at those two maps, it's the first thing that comes to mind. We see a lot more gray on the right side with the dental hygienists and a lot more blue with the dentists, which is our decrease. So really, really interesting. And we're gonna look a little bit more so at some of the details on hours worked. Because again, this is one person, we're measuring a person and we're assuming that they're maybe a full-time employee and that they're there to offer 40 hours a week of service to their community. But in reality, we know some dental providers, don't do clinical work. And so they may be out there and they be getting targeted as a dental provider that's in the system, but they're not actually out providing clinical services. So we want to do a little bit of a better dive into how many of these providers, and we see it a lot with dental hygienists or with public health dental hygiene practitioners, where they may hold the license but not actually be out there working. So it's hard to get an accurate picture of where the need's going to be the worst, but that's kind of where we're starting at this point. And I know Kelly's focused some of this on the rural side a little bit.
Absolutely. So if we look at just two examples of rural counties across the northern tier, so kind of third county from the left, third county or second county from the right, so McKean County and then Susquehanna County, what we notice is a very dark blue. Thank you for circling those. So very dark blue on the left-hand side of the screen, meaning there was a pretty significant decrease in dentists in those two rural counties. If we look on the right-hand side with hygienists, the number of hygienists has stayed the same. So if you have the same number of hygienists who are able to provide services, but fewer dentists for them to work for, now what happens? Do we lose preventive services as well? Or are more hygienists working for one dentist now where maybe they were working for two different dentists before? So again, we need to do a little bit of a deeper dive, but it looks as though we may actually have more hygienists than dentists to go around in some of these rural counties. And that makes sense when we go back to that ratio, right? So instead of 1-to-1, it is a little bit higher in rural counties. And so this is sort of a prime example of that. And we have to think through, are there hygienists who maybe like me still have a license, right, but not actually practicing clinically, or are there hygienists who may be looking for work in these areas? And if there were more dentists to go around, we would have more preventative services as well.
Mm-hmm. Mm-hmm.
I'd just like to add that I used to practice in Butler County, which on the map on the left is yellow. And I practice as a pediatric dentist, but to my knowledge, there wasn't another pediatric dentist north of Butler until you got to Erie County. Similarly, there wasn't another pediatric dentist east of Butler until you hit the middle of the state by State College in Center County. So that leaves 10 or 12 counties where the children were, who needed care could only see a select number of specialists that were closer to home. And the general dentists that were working in those counties, as you see, there are lots of dark blue. So there's been a decrease. They didn't have a lot of good referral sources that they had in their backyard. They had to send patients far away. And it was common that patients would come from well over an hour away for care, and sometimes multiple times, to get their care accomplished. So you could see that access to care shifting, and some offices had to stop taking new patients because of the demand, that it was just overwhelming their capacity to provide it.
We've heard, of course, the coalition gets a lot of this information, people just letting us know anecdotally where some issues are. And we've had a number of different individuals reach out to say that, they have people traveling from almost to the Northeast, almost in Lycoming County, traveling all the way to Allegheny County to go to the University of Pittsburgh for care. So definitely specialists add a whole other layer to this piece. And so, we've got to make sure that we're also considering how we enable our general dentists to serve the most people as well. So I think the next slide we're going to go to is pretty interesting. I think, Megan, you were going to talk a little bit about this one first, right?
I just thought that it was interesting that we were able to map out our neighboring states and compare the salaries in neighboring states to here in Pennsylvania. And on the far right, you can see general dentist annual salaries listed there, and Pennsylvania is ranked 5th of the surrounding states in terms of their annual salary. And you can see there's a huge discrepancy between Pennsylvania and Delaware, for example. So perhaps there's something to the salary component of this. You know, if the dentists were able to make more money, then potentially they would be able to pass that on to their hygienists and other staff, because everyone is being paid out of the same pie, you know, so you have to figure out how to make that work. But I thought that was very interesting to see that nationally we were pretty low.
Really low on the hygiene end as well. Second to lowest for hygienists out of the neighboring states. And you can see with the spreadsheet at the top, we have increased the mean annual salary from 2017 to 2021. But when, like, how much is too much, right? When can the dentists no longer afford to increase salaries for their staff? We know that reimbursement rates are stagnant. In some cases, I've heard some reimbursement rates are actually decreasing. So dentists are making less for services. Some of those are preventive services. So they're now making less, supplies cost more, or maybe they're making just the same and supplies still cost more, right? And so how much can one afford to be able to then pass on raises to those that are helping to keep the offices running? And so at some point, I think we're probably going to see those salaries even out. And there may be a point where raises are just not a possibility because there are so many other factors that go into keeping a dental office operating.
I think before we, I know we're going to talk a little bit more about this slide, but there was a question that came in that I was going to address to Sean about asking, you know, and I don't want to presume to know the answer because I'm not a data statistic person. But we did have a question asking about if this is all weighing into the cost of living in each state and how that affects this.
So no, this is a straight report. So think about looking at a tax return form and how much is on there and averaging out how much for each professional type. So no, it does not factor in cost of living. Good. It's a good call out though, because obviously in a lot of places in West Virginia it may cost less than it does in, say, Philadelphia. But this is just to provide a general report, really to say, you know, if we are trying to improve recruitment and retention of dental healthcare workers in Pennsylvania, there's competition because the states that surround us are also doing that.
Yeah. And I'd love to hear, you know, Lauren, we didn't say this already, but Lauren is an aspiring dentist. And so, you know, it was funny to work on this report with someone who is looking at these numbers and saying, so especially when we talk about how do we recruit more dentists to stay in Pennsylvania? Yeah, how did you feel about that, Lauren?
So like you said, as an aspiring dentist, I think you asked me a couple weeks ago if I'm still interested in enrolling in a dental program after, you know, learning all this information in the past couple months. And the simple answer is yes. You know, when you're in dental school, you're learning dentistry from the inside out. But I feel as if I have the upper hand learning dentistry and all the factors that are influencing it from the outside in. But that's not to say I don't have some concern or worry lingering in the back of my head that dentistry is not as good of a paying of field as, you know, I had once thought of. Because ultimately, dentists are doctors who specialize in oral health. So when you think about it, of 4 years of undergrad, 4 years of dental school, and that's not accounting for additional schooling if you want to specialize, that's really expensive, you know, the cost of education and just the average debt, especially since it's been skyrocketing since 1978. And I just think there was a lot more factors to consider, especially because the pay is not nearly as well as I had thought.
Definitely a factor. And we need to make Pennsylvania as enticing as possible. So for those who are on from other states, don't try to steal away our dentists by using these numbers. But I think it's pretty crazy. And I always point out every time we use Pennsylvania, we rank Pennsylvania against other states. I always point out that we are the 5th most populous state, right? So we are a big, highly populated state. And so you expect Pennsylvania to do better because of that. You would just expect that we should be up there in at least top 10. And we're not seeing that. So it's a little frustrating. So how then do we turn that to how do we get more workforce? How do we recruit more workforce? So this map, this is my favorite. This was the one that kind of made my jaw drop open and go, oh my gosh, because what this map does is shows our density, okay, the density, the just numbers per capita of providers that we have in each county. Okay, but then it also maps out where our training programs are. So where are our 3 dental schools? Where are our dental hygiene programs? Where are our known dental assisting programs? Because with dental assisting not being regulated by the State Board of Dentistry, it's a little bit harder sometimes to figure out where those programs are. We do know where the expanded function dental assisting programs are. So, we can map those out as well. But if you guys haven't noticed, the darkest counties have all the little squares and circles, right? So what we see here in, statistically speaking, is that we have a statistically significant correlation. Okay, so p-value less than 0.05. We're seeing that where our programs are is where our providers end up. So that's a big deal. Because if you're trying to fix a pipeline and you're trying to add more providers in very specific areas, this shows us that there may be some value in exploring where do we need to add programs. And I think that it's pretty obvious. We see there's a big difference in our rural counties. So across the top of the state, down through the center of the state, the T, everyone talks about the rural T. That's what we're seeing here, right? We see that we have not enough providers per person in those areas. One of the other things that we look at when we start to think about pipeline and how we entice people to underserved areas is we look at where are our first year dentists, once they graduate from dental school, where are they coming from originally? Because we know that we have a much better chance of keeping them here if they're from here originally. And so looking at the different percentages of who got accepted and enrolled into the dental schools in Pennsylvania, and were they from in-state or were they from out of state? And we see a pretty significant range there amongst the schools, anywhere from 12 to 14% in some years up to 42 to 48% for some schools in other years. And so, in our mind, we think, okay, well, if we can get these dental schools to take more students from in-state, we'll get more in-state dentists. We'll get more folks that want to practice here. We look at our out-of-state schools too. So West Virginia University is very close to the border. And we do know that a high number of their out-of-state students are from Pennsylvania. So we want to see that. Maryland, same thing. Crossover into New York. We want to try to figure out how to do that. And one of the solutions could be possibly even targeting students to enroll from the counties that are the most underrepresented here. So if you go to all of these applications for dental school and you say, well, who's from McKean County? Is anyone from McKean County? Because maybe that person would end up practicing in McKean County, which could help us out a lot. It's interesting. I know, Megan, you're now in West Virginia. So I don't know if you want to say a little bit about that process.
Yeah, I think there's definitely something to be said about the power of the academic institution or even the hospital system in the area, because as a private practice dentist, I felt like I was just drowning in treatment plans, and like there wasn't even room in my schedule to fit in emergencies, and there weren't any other specialists around me. So I mean, it was that classic, like you're just on an island plugging away, trying to take care of all the problems that come in your door. And I just felt like I wasn't getting anywhere. So I needed to swim upstream, if you will, and go to that next level of care, which would be at like the academic institution, and see what I could do from the training aspect of things to try to put a dent in this problem.
And it is a problem. So our next slide talks a little bit about Medicaid participation. I'm going to turn it over to Sean to open this one up a little bit.
So looking at Medicaid participation, which there's actually a decent amount of research showing that the quality of your Medicaid program can positively affect the density of providers in a given area, and that there is control for state agencies and state level leadership to be able to enact different changes through Medicaid coverage and reimbursement strategies within a state. And so that you can use that to help improve where you need to have more providers. The information is not great. It's not completely bad. The good news I'll give you first is that we did increase in the number of specialists from 2019 to 2020. The bad news is we significantly decreased in the number of general dentists. Overall, the decrease was about 13.5%. When you look at the most underserved counties that we have, or the regions that would need the care and the participation the most, many of them saw about a 25% decrease overall in provider participation. And this is with a 6.6% increase in Medicaid enrollees. And I'll point out that the predicted increase, or the actual increase from the COVID-19 pandemic impacts, is not really felt in this data. So the enrollees are a little bit, the enrollee information we have is a little bit behind the provider participation information that we have. And we would expect this, this chasm to continue to develop. Of interest is the amount of decrease in spending that occurred in 2020 out of Medicaid, almost a $74 million decrease in what was spent out of managed care organizations and the Medicaid program to dentists, which does seem to have severely affected the workforce overall, and also correlates with the decrease in participation. It'll be interesting for us in this next part 2. We actually have the 2022 dentist licensure data. And so we'll be able to start looking a little bit more at that with utilization in part 2, which I'm sure many of you are curious about. We did not run that data yet for part 1. We wanted more of an overview. We're going to get a little bit more into the weeds of where utilization is at. And just as a teaser, it's interesting because even though we lost almost a quarter of the spending out of the Medicaid programs, the services that were provided were within 12% of 2015. And so there were services being rendered, but the amount per service was decreased, showing that probably the more valued procedures were not able to be utilized through the COVID. So thinking about things like aerosols, maybe people were a little bit hesitant to get the drills out. Scaling root planing, things like that are all way down when you look at utilization. So we'll dig a little deeper into that and have a better understanding, and hopefully be able to understand where the money went a little bit better, because it was $74 million that was lost in paid out revenue. And unfortunately, that was not made up through the PPP program or the payroll protection program.
Mm-hmm. Absolutely. And it's always been a concern of PCOH when we look at Medicaid providers. We want more dentists to participate in Medicaid. We know that historically, year over year, we end up with about 23% of our general dentists participating in Medicaid. So we want to strengthen the Medicaid system so that more dentists want to participate in it. We want more people who are enrolled in Medicaid and depend on it for their healthcare to get more services. And so it'll be interesting to see where these numbers go over the next few years. And so happy to talk about that more offline with anyone who's interested, but something else we'll be tracking very carefully is looking into, of course, the credentialing process. How are these dental providers able to get credentialed with Medicaid? Can we make it any easier for them? We'd love to. And then also, many of you are aware that our state's undergoing new MCO managed care organization contracts that are going into effect September 1, which will pretty drastically change the landscape of which MCOs are offered in which regions of the state. So definitely, we've got some more information on that from some other webinars and reports and data pieces through PCOH. So keep that in mind if those come up as questions for anyone. So Kelly, DHIPSAs.
One of my favorite topics, right? So dental health professional shortage areas is what that DHIPSA stands for. And the map that we've included here, any of those goals counties are full county dental health professional shortage areas. So DHIPSAs can be calculated a few different ways. Facilities can be designated, or you can have a full county designated. And then there's portions of counties that can also be designated based on low income or special patient populations. But in this instance, we're looking at full county. And as somebody mentioned earlier, you see kind of across that northern tier, so very traditionally rural counties across that northern tier, down the center of the state. And typically we'll even say that sometimes instead of that T, it's a rural J. It kind of swoops under Allegheny County as well. So there are many of the rural counties included here in the DHIPSA areas. There are a few, thank you, there's our T or our J. There are a few rural counties who are not full county DHIPSAs. When we think about a dental health professional shortage area, I'm going to throw another ratio at you. So one dentist to 5,000 patients, and it's typically, there are more than that 5,000 patients, if that makes sense. So we have to be under that ratio to not be a DHIPSA. If there's more patients to providers, so it might be one dentist to 6,000 patients or higher, that's when we have a DHIPSA or a dental health professional shortage area. So in some of the more rural counties, there may be a handful of dentists that sort of, for that county population, that sort of helps with their ratio. What's not considered though is things like, you know, is there access to a Medicaid dentist? Is there access to a dentist that takes somebody's insurance? And patients may have to still travel out of county to receive those services. So two examples of counties that are not gold, that are rural, Elk and Cameron. And again, patients may still be traveling a distance even across that county to receive their care. And then two examples of counties that are actually urban counties would be Lackawanna and Luzerne County. They are actually urban counties, but still dental health professional shortage areas. So not completely, you know, all rural counties are dental health professional shortage areas. There can be urban counties that are classifying, and there can be, you know, some rural counties that are actually not full county DHIPSAs, but they likely do have some pieces or parts of that county, whether it's a facility or a zip code, that is still a health professional or a dental health professional shortage area. But if we were to lay the maps over top of each other, typically we see rural tends to be that dental health professional shortage area.
Thanks, Kelly. I'm going to jump in just real quick here on some of these particular counties. When we look at the counties that already have the health professional shortage areas, they have seen some of the biggest decreases overall from 2015. And when you look at that, a lot of these dentists actually went into these areas with a federal program that came out of the Carnegie Commission in the late 60s and early 70s, and provided additional funding to increase the percentage of dentists by about 20%. And a lot of that funding provided some different placement. A lot of these are old coal and steel towns, which back in the late 60s and early 70s were experiencing, you know, I wouldn't say a boom, but had a much better economy than they do these days. And so the dentists that have stayed there are retiring, and we don't really have a program or a way to facilitate a return to normal, if you will, in some of these counties. And so the health professional shortage is predicted to become worse. And that's detrimental to each one of these communities, where one dentist in a rural community can provide $340,000 in labor income. And if you kind of calculate this out, which we did in the report, it's about a $74 million per year loss in really economic activity, because a lot of that labor income gets spent in those local communities.
It is really interesting. The and we're seeing rural being highlighted quite a bit, in our state right now. And we've got one piece of legislation that passed last year to do an analysis of oral health access in rural. There's some other work being done looking at healthcare providers in rural versus urban right now, pending legislation. So I think we're going to start seeing this shift in focus, definitely in Pennsylvania, but probably nationally, to how do we address this problem and come up with some real permanent solutions. And again, so that's talking state level. If we move on to looking at a little bit of the regionalization, I know, Sean, you did a number of things here to really build this information out, right?
Yes, and this was probably the most fun, because you could really get into the counties and have a better understanding of what was actually going on. I think for me, the biggest take home was having good experience with national level data, and to get into the county level data and the discrepancies and differences between the two, and how difficult it really is to use national level data to inform county or even regional processes is interesting. I honestly was something I learned through this process. But regionalization is becoming more and more important. We're seeing a lot more of it, and it's to really hopefully allow for a much better bottom-up informational upload to inform policy and corporate structure. And so I think what we plan to do in the next part 2 is even delve a little bit more into this to understand the differences at the county level, and then bring regions together so they can help really input solutions. And there's tons of research from other countries that this works really well in oral health, to regionalize your state and really enact change at the local system. And with that, I'll go to the next slide, which is us highlighting what I think is the cool thing. As the kids say, I think it's fire. But this is the regional assessment breakdown, which is really a dashboard for each region. There's 6 health regions in Pennsylvania. We'll continue to move this to 2 pages with the next report, so we plan on widening this out. But if you're curious what's happening in your neck of the woods, or what's out your window, to borrow some of the famous weather people out there, this is the place to go. And I hope these regional assessments don't get buried, because I do think they're very helpful if you're living here or you're trying to make change in your backyard.
Mm-hmm. Yeah, there's a lot of information here. So hopefully everyone is able to see, especially, what's affecting the people in your communities the most. And I think too, we notice even, and I'll backtrack just one step just to show the differences across our state. To see the differences even just in those top 2 lines, looking at Southwest versus South Central. What the difference of just a few counties over or an hour apart can mean to accessing dental care. It's a really big deal. So, we hope that you guys are going to be able to use this information for the work that you're doing. And I do know, I think if she's still on, I think there was someone, did Jamie say? All right. I know we had a couple questions come in that we were able to grab during the call. I do want to just read a little bit of this information and some of the questions that have come through in the chat here and the Q&A. So Jess is asking, do the regions you are using overlay with the regional accountable health groups and the RACs, if anyone's familiar with the RACs? And I honestly don't know the answer if the RACs use the DOH health regions or not. Does anyone know that answer? I don't think they do, but I think they would be very close. Unless someone's going to correct me.
There's not a whole lot of difference. I think where the main discrepancy was at is really looking at the Southeast, Philadelphia, and then like Lehigh, sort of that whole eastern side of the state and where the cutoff is at. I believe we went with the bureaus because it looked like it was a better geographic and population-based designation of region.
Mm-hmm. Absolutely. Yeah. If they're not identical, they're pretty darn close. And that will be really, really helpful in terms of figuring out, how we get this information out there. It's a great idea, Jess, to maybe use those groups as a place to kind of launch some of this info. We did have another question come in about, has the state been approached about a centralized repository for credentialed dentists to decrease the administrative burden on dentists having to go through this process for multiple MCOs? So if you're not familiar with having 6 MCOs in our state, sometimes getting credentialed with each and every one of those is a major problem. And we know there's some pending legislation around this as well. So not just for dental, but sort of forcing the state to move to a universal credentialing process. Which I think sounds lovely. It takes away a little bit of the autonomy of the managed care organizations, but I think that that's definitely on the radar. I don't know if anyone else has any comments about that, but we want to make it easy. So, okay, hearing none, we'll move on. I know that let me see, next question. Data is presented. Are there any numbers that reflect the age of the dental populations? Since the ADA is predicting a large drop in the population of dentists in the next 5 years, is this true in Pennsylvania? And I know, Sean, you know a little bit more, and actually Lauren is probably, could probably talk a little bit about this too, that we did map out in the report, the age of the dentists and where they're at, right?
We did, and we're going to delve a little deeper into that in part 2 so we can look at hours work, because we did also see a decrease. Yes, I would say that when it comes to dentists, those that were licensed prior to 1980 had the largest and fastest attrition through the COVID pandemic. On the hygienist side, though, it was the middle bracket. So those between sort of 1981 and the late 1990s that we saw the greatest decrease in. So that's kind of how it fared out. When we look at burnout levels, though, we are starting to notice that there's a higher instance of burnout with younger dentists who are either working at multiple sites or working within a group or large practice structure. So more to come on that, but great. That's what we can tell you right now.
Nothing but teasers today. And so Dr. Thielen added, from a national perspective, other states must have similar disparities, which yes. What other models, if any, have other states done to resolve issues as represented in the data that we see today? Can Sean address this? Sean, any thoughts on what's been happening in other states when they're seeing these numbers come through?
So I think there's a range of, we need to do something right now to, this is just a typical fluctuation. I'm working with Helen, and we're working through with the American Institute of Dental Public Health to do a national scope so we can compare states. But overall, yes, in 2020, everyone experienced a significant decrease in workforce, most by about 12%. Where Pennsylvania differs is our hit in dental assistants was greater than most of the national, most of the states. And our hygienists are in the bottom, we're in the bottom half of rebounding to pre-pandemic levels. Some things that states are doing, I think a lot of them are trying to develop new workforce plans and looking at longer term planning, whereas most would be 3 to 5 year strategic plans. It's now 8 to 10 year strategic plans. We're seeing a lot of federal money start to be brought into states. This was a workforce grant in and of itself to see how we can maneuver the workforce out. My concern is I hear a lot of, okay, well, the dentists are decreasing. It seems to be affecting rural areas. Let's try to get dental therapists into those areas. And when we took a step back with this review, it's the entire dental economy and dental workforce. The most fun thing about this sad report really was that we really started to see how dental lab technicians and their decrease is impacting access to care, and how individual dentists who may not be clinical can slow care down. For example, if a managed care organization does not have enough dental consultants to review a claim, it slows the process down and backs things up. So we're trying to study that in a little bit more intricacy. So sorry, it's a little bit long-winded of what you probably were hoping was a short answer. But right now, I think everybody's trying to figure it out. There's very few states that made it through this okay. And the national data from all dental care workers were still anywhere from 3 to 5% from pre-pandemic levels after what was a devastating 15% loss of entire workforce. My main other concern is just the burnout levels. So it's not going to be a easy systems change fix that we have to really delve into what do we want out of dentistry and how does the workforce want to maneuver in that?
Thank you. Thank you. I want to give, we had one attendee raise her hand, or raises her hand there. I just wanted to try and bring them off of mute to ask their question live if possible. So hang tight. Let me see if I can do that. All right, Jamie, you should have the ability to speak now if you're still there.
I'm still here, but I actually put in the credentialing comment.
Oh, all right. Awesome. Thank you. So we addressed that. I appreciate that.
Yep.
Thank you.
Yep. Thank you very much, Ellen. Very
Sure, no
informative.
problem. Great. And then Dr. Hassan, let me let you ask your question. You should be good to talk now.
I'm sorry, I didn't have a question. It was an error.
Oh, okay. Well, that was an easy one then. Thank
Yes.
you.
A lot of the topics has been, as far as I know, has been discussed in Pennsylvania, and a lot of groups of educational institution are trying to resolve so many of these issues that we face today, and we have been facing shortage of dental providers for a long time, but COVID made it even worse.
Mm-hmm. Yes, absolutely. Absolutely. That's what we, really wanted to dive into and to see. We knew we were already on a decline. So how do we then judge how much worse it's going to get? And none of these solutions are short term. That's something that I do want to say. Some of these other states have done some more loan repayment programs, pieces like that. But what we have seen is that none of them are short term. These are 3 to 5 to 10 year solutions to fix some of these problems. So, and it's something I think we're going to be forced to address in the next 5 years for sure. So any other closing comments from some of our panelists here, or anything else you guys want to add in our last minute or so?
I would just like to say thanks to this group, and then I want to bring a little perspective from whenever I was working in private practice, like for the patients. I know that we were getting patient treatment plans and booking out 5.5 months to start treatment on regular care plans. And we were fortunate enough to have the services of a dental anesthesiologist in our office. And we could treat between 9 and 12 cases a month with full mouth cases and rehab that way. And those cases were booking out about 3 months as well. So I left private practice in April of this year to come to academia and start to tackle this problem. And work groups like this are the first step in identifying what the problem is and then, trying to get in there and fix it. So thank you.
Any other comments? Lisa, I'm going to let you come off of mute here. I see you had maybe a comment or question.
I did. First of all, I wanted to say thanks so much for this great report. And, since our office works across all of the provider types, this is so consistent with what we're seeing with primary care physicians and primary care in general. And I think that looking at this as a holistic approach, I mean, dentistry and primary care, really, I think if you were to use a Venn diagram, they would almost overlap. And that is why it is so important to be thinking about the integration of oral health into primary care so that we can be assured that at least some of those services are being provided. So that's all I wanted to say. And I just wanted to say, thanks, Sean, and for leading the report, and Kelly, of course, since I know her just a little bit, and Helen for funding it.
Oh my gosh. Well, thank you very much, Lisa. And just, I know everyone's starting to pop off, but we just wanted to throw in there, if there are pieces of things that you think that we could maybe try to address or look at, I did stick an email into the chat there, our info@paoralhealth.org email. If there's something that you're like, hey, did you think about looking at this data point, or hey, would you like to, investigate this a little further? As we start to work through part 2 of this report and dive in a little deeper, it's great to get the perspective of everyone out there. We can't make any promises, but if there's more we can do, we certainly will try. So thank you very much. I think that about wraps us up for today. And again, as always, keep in touch and let us know if there's anything that we can do for you. So thanks to everyone for joining us today too, all of these great panelists. That was really lovely to work with you all. So, all right, everyone. Have a great day.